Good morning from New York. This 25th of April 2012. We're very excited to have the monthly vascular webcast. This is transmitted live from www.peripheralvascularinterventions.org, and this page has been viewed for 9,000 times. I want to remind you before we go to the case that the next website is going to be on May 23rd, the same time, 8 a.m. Eastern Standard Time, from the same website. And also to remind everyone that in June, from 13th to 16th, we have the live symposium of complex coronary and vascular cases here at Mount Sinai in New York City. And you could register with significant discount at www.cccsymposium.org. Let me remind everyone that this symposium includes a nurse and tech session on the 13th, which is a Wednesday, coronary cases on the 14th and 15th, the vascular cases on the 15th, and a bore review course on the 16th. Without further delay, and we can get a little bit more of the logistics later on, I would like to remind you that throughout this case, you could go to the Ask a Question part of this website. Just click and submit your questions. Dr. Krishnan and I will be happy to address them during the live webcast. And at the same time, if you happen to have reviewed any of the past sessions and you still have questions about those, you can also submit them. Those will not be answered live, but we will send you an email back at a later point answering your technical or other questions you may have. So without further delay, let's connect with the cath lab and meet PK. Dr. Krishnan, good morning. Welcome again to the monthly vascular webcast.
Good morning, Dr. Dangus. Good morning, George, and everybody out there. So we're ready. We're presenting a patient who's kind of a typical patient that any one of us may see out in the community. And I'm going to have Dr. Wiley go ahead and present the case in a second. Just getting things ready here. But prior to that, I just wanted to welcome everybody, as Dr. Dangus did, to our monthly webcast. We're very excited to obviously bring this to you from Mount Sinai Cath Lab. I'd like to introduce my team. I have Ray Lascano, our interventional nurse practitioner here, who assists us in our interventions. I have Elizabeth Holton and Rick Ricardo, who's our technician, and Elizabeth is our nurse. With me, I have the pleasure of Dr. Wiley in the cath lab with us, and he's going to go ahead and present this case while I take some angiographic pictures.
This is a 67-year-old patient with a history of hypertension, hyperlipidemia, COPD, TIA in the past, peripheral arterial disease with a Rutherford Class III right buttock and hip claudication. She had a peripheral angiogram performed before that shows severe calcification of the right common iliac. So the plan for this patient will be angioplasty and stent of the right common iliac.
So this is a lady who has got classic buttocks claudication, and she has a high-grade right common iliac lesion, which obviously you're going to see in a second here. We're not been given enough dye to really show it, but we've got diagnostics earlier. I'm going to show you some gradients. So basically, she walks and she gets pain in her buttocks that limits her from walking. Now this is very typical, obviously, for patients. I'm going to give about 4,500 of heparin, guys. Okay. This is typical for female smokers, as we know that female smokers are more commonly affected with the iliac, and it's very, very common to present with buttocks or hip claudication. Now, if you're a male, obviously this may also affect you in terms of erectile dysfunction, and often, I mean, I know that we've seen it here quite a few times, that clearly that these patients are misdiagnosed as having arthritis and then are being treated for arthritis rather than really for their vascular disease. Now she had a workup of ABI and PVRs at our hospital here, and clearly showed a high-grade lesion with high velocities at the level of the right common iliac. Now I just want to go over what we do. I want you to hold your breath, okay? Hold your breath. So I'm going to take a deep breath in. Take a deep breath in. Let it all the way out, and don't breathe. So our technique, and I think it's important to go over technique of what we do here. You can see right there, you got eccentric, high-grade calcific iliac on the right side. The technique of how we breathe normally, honey, how we normally fix these is what I really want to go over. On the right common femoral artery, while we were trying to get access, we had no pulse. We really could not feel a palpable pulse. So one of the things we do in these kind of cases when you have such a high-grade lesion is to go ahead and get left access, put a catheter up in the aorta, and then go ahead and do fluorofade. If you can go to the screen, I'm going to show you what we did. So what we did prior was we injected from the aorta, and then we went ahead and saw the common femoral on the right side. And so rather than stick blindly, we did fluorosave of this particular shot, and then we went ahead and accessed with the micropuncture kit. So that's one way of getting access, because in these kind of cases, sometimes getting access can be quite difficult. The second thing is, the other option on how to get access in these difficult cases would also be to use a ultrasound-guided technique. So you know that the ultrasound needles are available, so you could try either ultrasound needle and direct puncture of the common femoral artery, or you could do, obviously, ultrasound-guided by having a handheld ultrasound identifying the common femoral artery and make sure that you stick along the right aspect of the femoral artery. Once we get access here, we've got a runoff earlier, and I'll tell you that she's got diffuse SFA disease bilaterally. She's got a two-vessel runoff into the foot, and really just a focal right common iliac lesion that you see in this angiogram. So then the question becomes is how we're going to fix it. But two things I got to tell you here is it's important in calcific lesions to make sure that you have your bailouts in mind. So one of the things that we always teach here, all three of us, George, Dr. Dangus, myself, and Dr. Wiley, is to make sure that you have a sheath large enough to manage with your bailout stent, especially in calcific iliac disease. The second thing, so in this instant, we went with a 7 French pinnacle destination sheath. Important part of that concept is also to look at the sheath. Now we're going to zoom in on the sheath on the fluoro. When you zoom in on the sheath on the fluoro, you see a marker. That's very important, and this is a marker sheath for those of you out there who are going to be using this. This marker will be able to teach you for two things. One, for you to be able to measure the iliac, you can use the sheath to measure. Or two, you can go ahead and also see the distance between the distal edge of the lesion and your stent. So there's two exact areas why you want to use this. The reason we chose a 7 French sheath is, again, because of our bailouts. Now, we use Atrium ICAS covered stents here, and you know, we can go up to a 7 or an 8 without a problem, and obviously expand that even bigger through a 7 French sheath. Obviously, there are other covered stents that are available. You know, I know Bard Fluency is available as well as others, but in our lab right here, we do have Atrium and we do have the Gore Viabond stents, both of which will go through this particular sheath. But obviously here, since it's in a common iliac lesion, we would want to go with a balloon expandable covered stent if we need a bailout. So these are the initial thought process that goes in. So one, how to get access. The contralateral access is not always necessary, but in case you don't have a pulse, it may be necessary and may hasten your ability to be able to get into this vessel. Two is obviously, doing this under either ultrasound guidance or fluoroscopy guidance, getting access. Three is your choice of sheath and your thoughts on your bailout, especially in calcific iliac lesions. And four is your anticoagulation. Now, we're a large bivalve-Rudin lab and probably use bivalve-Rudin on 99.7% of all our interventions, regardless of coronary, peripheral, or aortic valve disease that we do here. So here, clearly, because of the area that it is a abdominal vessel or a retroperitoneal vessel, and here we're going to go ahead and balloon their calcific vessel, there may be a chance of rupture. We went ahead and used heparin rather than bivalve-Rudin just to give us the comfort for us to be able to go ahead and do the reversing if we need to. So we've got all the thought process, and it's important for those of you out there who are doing this. And looking at this, you say, hey, listen, it's very simple. And you're right, it is a simple lesion in terms of how you're going to do it. But it's very important to have the concepts down in terms of what can happen and how you're going to bail yourself out, or how are you going to take care of this properly. Lesions like this should be done quickly, rapidly, and safely, so that, first of all, you're benefiting the patient in terms of the patency, and second of all, you obviously don't want to create a major complication wherever you are.
PK, you had a very, if we go to the slides back, you had a very interesting slide with the schematics of the iliacs and where the lesions are and what could be the preferred treatment. I think can we review that a little bit?
Sure.
Because that has a lot of didactic value on planning the procedure, which is very important.
Absolutely. So I'm going to have Dr. Wiley go over that. That's why he's here. We got all that ready for you. And
yeah, this one, exactly.
Yep. Go
Jose,
ahead.
perhaps you can guide us
Absolutely.
through this while PK sets up the case, and maybe if we go to the angiogram, we can keep that a little bit on the side so we can, you know, continue to talk about that.
Go ahead,
Sure, George. This is actually very important. The task 2 divided iliac lesions into 4 types: type A, B, C, and D. E being the less complex ones, D being the most complex one. And this is important based on the fact that type A lesions are preferably treated endovascularly with balloon angioplasty and stent. Type B lesions are also best treated with balloon angioplasty and stent. And type C lesions are better treated surgically, as well as type D lesions. And let's go into details of what are all these types of lesions. For instance, type A lesions are unilateral or bilateral stenosis of the common iliac. Unilateral or bilateral single short less than 3 centimeters stenosis of the external iliac. Type B lesions are multiple lesions, each of less than 5 centimeters, or short less than 3 centimeters stenosis of the infrarenal aorta. It also includes unilateral common iliac occlusions, single or multiple lesions totaling 3 to 10 centimeters, involving the external iliac but not extending into the common femoral artery. It includes also unilateral external iliac occlusions not involving the origins of the internal iliac or common femoral artery. Task C lesions, which I mentioned, that do better treated surgically, include bilateral common iliac occlusions, bilateral external iliac stenosis between 3 and 10 centimeters long, but not extending into the common femoral artery, unilateral external iliac stenosis extending into the common femoral artery, unilateral external iliac occlusions that involve the origins of the internal iliacs and or common femoral artery. It also includes heavily calcified unilateral external iliac occlusions, not common iliac, but external iliac occlusions with or without involvement of the origin of the internal iliacs and or the common femoral artery.
Dr. Wally, can you show the schematic? And
Sure,
with the
sure.
schematic?
We're going to show it in a second. And lastly, the type D lesions are the ones that include occlusions of the infrarenal aorta iliacs, diffuse disease involving the aorta and both iliac arteries, unilateral occlusions of the common iliac and external iliacs, bilateral occlusions of the external iliacs, and iliac stenosis in patients with abdominal aortic aneurysms. So essentially, all I talked about is this schematic diagram. So as we stated before, the most discrete lesions are type A lesions, and the worst are the type D lesions.
That's fine.
So over here, we're kind of in an A plus because it is isolated. However, one can say it is probably pre-occlusive because of the heavy calcification. So it's somewhere in between A and B. It's technically is A, but I would say probably the most advanced type A lesion.
Correct, because the task 2 classification doesn't mention anything about calcification. In the common iliac, it does in the external iliac.
Yeah.
If the external iliac was calcified, then it would be a type C lesion.
Yeah, and the reason for that is that the external iliac is very tortuous at the bottom of the pelvis, whereas the common is rather straight up top, you know, right off the aorta. So, you know, these occlusions of the external iliac also involve excessive angulation and tortuosity.
Correct.
So, PK, one more question. Since you put another catheter both groins, can you give us a flavor of what's a pressure drop between the 2 catheters in this lesion before you start?
Yep. There's a 40 millimeter resting gradient as we speak. And more importantly, if you look at what you have here on this particular angiogram, you can see you have a very, very calcified lesion. I don't know if you can see the second angiogram we just did.
Yes.
So you have a very calcified lesion. Now, there's multiple different ways in which you can go ahead and treat this, George. Well, I mean, what we normally do is we try to do serial balloon dilatations, and then we go ahead and do it. Now, 2 things that can obviously occur are distal embolization during this. So since we have a prior angiogram, we can go ahead and, in my opinion, save the contrast and go ahead and do a final runoff. If you're doing this for the first time, and this is the first time that you're seeing this and you're about to fix it, it's extremely, extremely important for you to go ahead and do an abdominal aortogram or an iliac pelvic angiogram followed by a distal lower extremity runoff.
Exactly.
So here, now we've got the 7 French, we've got everything done. We gave the heparin, what's our ACT? It's 232 and going. We like to keep it around 285 to 300 in these type of cases. And we're going to go ahead and start to do angioplasty. I believe it stopped at 245, so we'll give another 500 of heparin, and then we're going to start. How we decided to do this is to go ahead and do balloon angioplasty and stent. And since the lesion is not located at the junction of the common iliac, I think it's interesting in terms of talking about the choice of stents. It's clearly a common iliac lesion, but it's not an osteal common iliac lesion. So therefore, it gives us some choices in the stenting, and how we decide here is based on the behavior of our balloon, okay? So if we have a relatively easy balloon expansion, then our choice may become different in terms of whether we're going to go with a self-expanding stent versus a balloon expandable stent. If it's aorta osteal, by far in this lab, about 97% of cases are done with balloon expandable lesions because of, one, the preciseness of our placement. We'd like to place it, not too much into the aorta, obviously, but at the same time covering the ostium. 2, the radial strength, which is going to give us enough radial strength to be able to expand it against the fibrous and calcific osteal lesions that are typical. And obviously 3 is the radial strength, which is also going to help us. But here, since it's a little bit further away from the ostium, we may be able to get away with a self-expanding stent. The advantages and the disadvantages of both are kind of simple. Obviously, in the ostium, I don't think there's any question. You have to size 1-to-1, and you want to go with a balloon expandable stent. In this particular area, there's usually a problem. In a tight stenosis such as this, you may have post-stenotic dilatation. So a lot of times, if you place a balloon expandable stent, you're going to have what we term as stent swinging in the breeze, especially distal to the in the post-stenotic dilated segment. So therefore, what Dr. Wiley and myself have done is we balloon angioplasty the particular lesion. We see how it behaves. If it behaves well, we're able to get good expansion of the balloon. Then at that stage, we go ahead and place a self-expanding stent, oversize the self-expanding stent so as to be able to first cover the lesion, then to also be able to adhere to the post-stenotic dilatation. In this particular case, you don't have much post-stenotic dilatation. So in this case, it's actually quite easy. There are other cases that I can show you, or I'm sure that you'll see in your practice, where you'll have a tight stenosis, which is very narrow, maybe a 7 or 8 millimeter common iliac above, and maybe a 10 or 12 millimeter common iliac or external iliac below. So it's very important to learn from the dilatation of the balloon. Now, as far as the balloon, we're going to start very conservatively with a 6 millimeter balloon, and it's probably extremely undersized, but I want to go up and I want to just show you guys how this looks. Now, we've given an extra 500 of heparin, and we're going to go up with the balloon here. The balloon has a little bit of, it's a little tight to push it. I had to push it hard. I'm just going to give diaphragm above fluorophage, guys. So we're going to give it a little roadmap, and the advantage of having this also for teaching purposes is to be able to show you the balloon expansion and where we're going to balloon. So you can see here, the balloon is across the lesion. Now, this is a 6 millimeter balloon. If I was going with a 10 millimeter or 12 millimeter balloon, you want to be very careful, especially in a severely diseased distal aorta. When you're dealing with a common iliac lesion, you don't want the balloon to extend into the distal aorta at times, and then you may cause distal aortic dissection or plaque rupture. So we're very careful to make sure that we stay out of the distal aorta. And here also, you can see here, you have a little moderate lesion or mild lesion in the distal common iliac / maybe early external iliac, really distal common iliac. So with a 20 millimeter balloon, we're going to avoid that. And I'm going to ask Dr. Wiley to go up slowly. And there are 2 things we need to watch for. One is we're watching for bradycardia. And 2 is we're going to watch for the expansion of the balloon. Come on, fluorophage, guys. What we learn from the expansion of the balloon is how the balloon expands. Now, you want to see that balloon expand equally. You don't want to see differential expansion, meaning outward push. If you have a heavily calcified lesion, what you're going to have is, and that lesion is non-giving, the healthier part of the wall is going to give. So therefore, if you watch the balloon expansion, you will learn as to how this lesion is behaving. Currently, as you see by this particular live fluoro, there's a little bit of a dent. It's a 6 millimeter balloon. So we're okay with this. She's not having any pain, and there's definitely no bradycardia.
We're at nominal right now.
We're at nominal, and we always only go to nominal. As far as bradycardia and pain, it's important to remember because bradycardia and pain are signs of impending rupture. So therefore, you definitely do not want to go up when the patient's having pain of bradycardia because of adventitial stretch, and therefore you're overstretched. Now we've gone ahead and taken this picture. Now what I'm going to do is ask Dr. Wiley to just I'm going to move my sheath up a little bit closer. I could cross this if I was worried. Since I have pressure, I'm watching the pressure. I'm trying to see exactly if there's a pressure drop, then I know that I've perfed, or I know that there may be a problem, then I'm able to push the sheath across up into the aorta. But in such a small balloon, we know that's not going to happen. So we're going to walk this out. We're going to take a quick picture from above, and I just want to show you what we're dealing with. And then we'll decide whether we're going to direct stent or choice of stent. Hold your breath, my dear. Ready? Inject. So we've made a little bit of a dent, not much of a dent. So I'm going to go now with that. I'm going to jump right up into a 7, and then I'm going to ask for an 8-millimeter balloon as well. Now, this may also be a little bit of recoil because of the fact that because of the calcium that's pushing in. The balloon expanded well, but it was a very, very small size balloon. A lot of people would argue is why not just measure and go, and I think that's the right thing too. If you want to measure, go 1-to-1 with the balloon size and go, that's fine. But for those starting out, I think it's good to be conservative, and I'm just showing a little bit more of a conservative approach in how to do this. So here the balloon went much easier. Just going to give a little test from above just to show you that we're above or we're below the common iliac, which we are. So I'm going to ask Dr. Wiley to go up, and now I'm going to watch the balloon expansion from below. Go up slowly, guys. Up. So we're going up here. It's a little bit larger balloon, 7.0 by 2. And you can see here, now you're going to go up a little bit more. 3, 4, 5. What's nominal? 6. Go to 6. Okay. Now I'm not necessarily going to take this any higher. I just want to leave it at nominal. And one of the things that we can also talk about is whether or not we can go with a larger balloon here. So I'm just going to go ahead and leave this up for a little bit. Okay. Down, guys. Now one of the things we could do is check a gradient at this stage, and then see whether we've gotten rid of our gradient. So let's see. Let's take a picture first. Walk this back.
Prakash, for the purpose of the discussion, there's some people utilize.
We gave 500, right? Okay. Hold your breath again, huh? Inject. Okay, so we have this really, really calcific lesion that's really not giving as much as we want it to. So another important lesson is to talk about when you're going to stop ballooning and what you want to do. So here we go ahead, and I'm going to go ahead and I'm going to do a gradient. I did a gradient earlier. So
yeah, I think it's very important to do the assessment now because we haven't seen much difference between a 6 and a 7, a little bit of an increase. So one can say that even if we put an 8, we're going to, create some progress, but still there's going to be quite a bit of residual indentation due to recoil or essentially recoil of a normal part of the vessel. What's happening here is that there's a rigid plaque, and then the normal vessel expands the other way, and obviously recoils for the most part right after.
Well, interestingly, George, as you can see here with our gradients, we've gotten rid of the gradient. So you can see here that you have no gradient after 2 angioplasties. So maybe there was something in there that the calcified nodules that were reaching in. And you can see here that it's important in iliac disease to really treat gradients more than anything. So now you're not going to gain any benefit by going up further. The only question is whether you're going to stent it to prevent late recoil of this particular disease. As we know, in iliac disease, stenting has been superior to balloon angioplasty in all of the trials. So clearly, in this particular lesion, you do want to stent. I'm very happy with this. I'm actually very pleasantly surprised that our gradient is gone. And since, I don't know if you can see that, since our gradient is gone, can they see that, guys?
No, we don't see the gradient yet, but keep in mind this is a resting gradient, and indeed patient may have developed an extra 20 millimeters or so during exercise.
Right. So
there may be some type of, unfortunately, we do not have a very good hyperemic agent for peripheral vascular disease, same way that with such confidence we use in the coronaries with the adenosine infusion and the FFR. So we're sort of limited in that part. And I think if we had a stressor like that, would make the interventions in the peripheral lab very, very much more comprehensive in that respect.
Absolutely.
Don't you agree, PK?
I totally agree. I mean, and I think, but the heartening thing here is that there was a 40 millimeter resting gradient.
Absolutely.
And so now we've abolished that resting gradient, but your point is very well taken. If that 40 millimeter resting gradient was an exercise gradient, it might have been an 80 or a 90, and now that we have none, you may still be left with a 20 when this lady does, or when this person does exercise. So therefore, I, as far as I'm concerned, I really want to go ahead and at this stage discuss with yourself and Dr. Wiley on what we need to do. Do you think the choices, I mean, for me, sitting here looking at this are two. One, I can go with an 8 or a 9 millimeter balloon and try to expand this further. Or two, we can talk about stenting it and the choice of the stent that we should use.
You know, I think for the purpose of the discussion, I think it's interesting to talk about the role of cutting balloon. Some individuals advocate their use. I'm not a big fan of them. What's your opinion, Prakash?
I'm sorry, Dr. Wiley?
Regarding the use of cutting balloons, I'm not a big fan of them, but some individuals advocate their use in a calcified lesion. What's your take on?
Well, that's a good question. I mean, as far as cutting balloons in the iliac, I mean, they have been studied, and for me, again, I go more with gradients. I mean, if I have a lesion that's recoiling and producing a problem in terms of a resting gradient, that's the only tool that I have to decide in the cath lab on when I'm going to be able to stop. Like Dr. Denga said, I don't have a good hyperemic agent here to tell me how this is going to behave physiologically under exercise. So therefore, I'm going to focus on my resting gradient. If I have a calcific lesion, I had a 40 millimeter gradient to start with, and now after a balloon angioplasty, I've eliminated that 40 millimeter gradient. There has not been any recoil, but I do have a filling defect in the lumen or extraluminal. So the question here becomes to me, the addition of a cutting balloon, I don't know how much it's truly going to add. The balloon expansion was fine. You can argue we were not one-to-one. So therefore, maybe the question could be, well, do you want to go with a larger balloon?
PK, we have an interesting question that I think we need to address from our attendees. They're asking regarding orbital atherectomy or other calcific plaque modifying technologies, which they're familiar from the coronary circulation.
Well, that's a great question. Unfortunately, at this stage, in terms of the iliac, as far as, indications for doing anything other than really laser, with the only thing that we've done with laser, it's again off-label to go ahead and do an in-stent restenosis. We've run a laser through in the iliac. As far as orbital atherectomy, I myself don't have any personal experience, but I can tell you two different things. One is this vessel is at least a 9 or a 10 millimeter vessel. I think all of us would agree, and we could do an IVUS to go over that. So therefore, the maximum vessel diameter that we're possibly going to get with the orbital atherectomy is maybe 4 or 5. As far as we go with a pathway medical atherectomy, the maximum you're really going to get is about a 3.1. So you're not going to be able to get a big enough lumen, and you're really not going to be able to address that plaque. So number two will be Fox Hollow or Silverhawk atherectomy. If you do Silverhawk atherectomy in this particular thing, again, it's contraindicated or it's not indicated in this particular area. It'll be an off-label use, but again, you're going to face the same problem with directional atherectomy. I don't think you're really going to be able to modify this, and iliac calcium is a major issue to deal with.
Yeah, so, I would also agree that these devices are a better fit for the femoral and popliteal vessels where you have a long lesions or rather smaller lumens. They're not really designed for these very huge lumens of the iliacs, let alone that there would not be much of a support of the device with a distal wire hanging in the aorta and try to manipulate that, to hold the device in track and all that stuff. So
actually, that's a great point, George, because I'll tell you, once you go with an 014 wire in this particular area, and all those devices go over an 014 wire, you don't have the support to be able to bail yourself out.
Yeah.
If, God forbid, you do try it and, you're heroic enough to try it, if you get into trouble in some ways, now you're in trouble. The second point with these atherectomy devices may be distal embolization.
Yep.
So if you have the distal emboli going down, and here you probably will have macroscopic emboli rather than microemboli, and also you have to question if you're using the pathway, the ability of that to particularly suck out the debris. I think you're just asking for a whole world of hurt. I think I think clearly Dr. Wiley's point of a cutting balloon may be reasonable, but I think at this stage, I mean, you know, if to me, if you're going to balloon further, you balloon with a larger balloon, or you go ahead and finish the procedure with a stent. And I think the choice of the stent becomes paramount here.
I agree, as Prakash was saying, the cross-sectional area that you're going to achieve with the current atherectomy devices are not going to be greater than the cross-sectional area of the lumen that you see right now.
I think we had a great result we had a great result eliminating the gradient with this couple of balloons. I'm not sure another balloon is going to really heal that much. So I think it's probably time to discuss a self-expanding versus bare metal, covered versus not covered. So we have like 4 stent choices here.
Exactly.
And I think those are, and I would also say that also another parameter is the short, a 20 millimeter stent, or a long, like a 40 millimeter stent, because there is a little bit of an extended calcification further down in the rest of the common iliac, and one can say that once we intervene, maybe just cover the entire lesion, and you know, that might sit the stent a little better. So we have quite a few choices.
I tell you, Dr. Dangus, that's a phenomenal point, and I want to illustrate that. The sheath is across that second lesion, moderate, what we think is a moderate lesion. So what I'm going to do is just pull it back. I want to make sure that we're not missing a gradient, okay? And I'm going to pull it back down below, and you can see here there is no gradient that occurred, as long as you can see that. And I think that's a very important point that Dr. Dangus makes, because in these type of calcific iliac lesions, there's always a chance that it may be eccentric. And in the one angiographic view that you're seeing, the second lesion, this moderate lesion, as you can see in the aortogram, doesn't look that significant, but you may have a significant associated gradient with it. And I think that's an important point. So now what I'm going to do is take another picture at this level. Ma'am, can you hold your breath, please? Hold your breath. Just want to take another picture here. You can see here we've taken an eccentric view, and you can see that there is absolutely no difference in the distal lesion, and there's no difference in the gradient. So now the question is, and I'm going to leave it to you and Dr. Wiley to guide us both to guide us through this, is should we use a balloon? I just want to bring this up to you guys: a balloon expandable stent, a balloon expandable coverage stent, or a self-expandable expanding stent?
I would say that I would prefer a self-expanding stent at this point, and I would say that I would also prefer a covered stent, and you know, this will enable us to dilate with a 9 millimeter balloon afterwards and expand it a little bit better. I would not dilate this with a 9 millimeter balloon if the stent is not covered. If we go in the non-covered stent, I think we have to go with a balloon expandable, and we have to trim down our size expectations, that maybe we can put an 8 millimeters balloon expandable stent, balloon expandable stent about 40 millimeters long, and just accept that it's going to have maybe a 20 or so % residual in its proximal part, but again, this is not going to be gradient generating.
Dr. Wiley?
I agree with you, George. However, I'm going to reiterate a teaching point that I've heard Prakash teaching our fellows. He quotes on several occasions, there's a trial called the Cobas trial. It's a Austrian trial that included approximately 140, 150 patients. The randomized patients into cover stenting versus bare metal stent. And these patients were divided into task A, B, C, and D lesions. And it panned out that in task A lesions, bare metal stenting was equal to cover stents. However, in task C, and particularly in task D lesions, cover stents were superior in terms of binary restenoses. So, you know, we have several choices here. The other point, whether we should use a balloon expandable or self-expanding stent, it actually does not extend the lesion into the ostium. So I think we could get away with a self-expanding stent and be able to position it appropriately.
And also the fact that, you know, here basically that the balloon expanded well and we've gotten rid of the resting gradient also gives me a lot of confidence that if I do put a self-expanding stent, have a little bit of recall, I should be able to open that with a larger balloon. The important thing, I think what Dr. Wiley's point is extremely good, is that I think when we make these decisions, you want to make evidence-based decisions. And here you do have a trial, even though it's a small trial from Austria, it is what we have in this particular type of disease lesion. So here, you know, the question begets is, what type of task lesion it is. And I'm going to leave that to Dr. Wiley to discuss, the task in this particular lesion.
Yeah, as we discussed earlier in this presentation, this is a very short lesion in the common iliac. It's less than 3 centimeters, so it really falls into the task A lesion. So here, actually, we could use either bare metal stents or cover stent. The results are actually similar in both of them.
So therefore, in terms of so having evidence suggesting that we can go with the bare metal stent, that would be one tick towards that. The second technical caveat that I would want to throw out to all of you out there is very, very simple, is what are the technical things you as an interventionalist have to know about while you're placing the stent? Okay, well, is it going to be difficult to be able to be precise? That's a great question. So you have a large gap, and I'm going to have Ray just give a little angio. Hold your breath here, 1 second. Hold your breath, hold your breath, hold your breath. Okay, inject. That's fine. Okay, you can see here, once we toggle and freeze this, you will see that there is actually a nice gap for you to be able to place it. So you can actually flare the self-expanding stent up into the quote-unquote normal segment of the iliac and then bring it down. You can also see the other thing is that there is a little bit of a size difference between the distal common iliac and the proximal common iliac. So therefore, if you put, say, a 10 millimeter a balloon expandable stent, you may actually have that issue of, well, now I'm going to have this too big in the distal, and as we know, like in the renals and the iliacs, you really want to try to be 1-to-1 rather than more than 1-to-1, because more than 1-to-1 portends to obviously rupture the vessel. So here with the expansion, if you want to cover it, you don't have a good landing zone distally, because I would probably go with a 9 or a 10 millimeter balloon expandable stent here. So at this stage, what you could do, in my opinion, the safest thing to do, since you've eliminated the gradient at rest, you go ahead and now place a self-expanding stent across the lesion and then go ahead and balloon it. So you can use a longer self-expanding stent, oversize your self-expanding stent a little bit, so this way you cover the proximal larger common iliac, and yet at the same time are going to be 1-to-1 or a little bit more than 1-to-1 in the distal common iliac, which as we've known many years, our techniques stenting has been to use oversized stents either in the SFA or the common iliac, especially with self-expanding stents. So we're going to go ahead and do that, George. We're going to agree with you as well as Dr. Wiley and go with the self-expanding stent here. I'm just curious whether anybody in the audience or who's listening has sent any comments regarding what they would do or their experience in these type of lesions. Self-expanding.
Yep. Not as of yet, but I think it's very important to understand that the critical part in sizing that is that we have a very good margin between the top of the lesion and the aortic bifurcation. We have a healthy 5 millimeters or so, or 10 millimeters actually. And the self-expanding stent, maybe a 9 or a 10 millimeters, is going to nicely oppose there.
Well,
then
that's a great point, George. I'll tell you, because we're just discussing what size self-expanding stent to come. And I come from the school of thought where that proximal iliac is at least a 10 to me. So I'm going to go with a 12 here. I'm going to make sure that I'm well opposed against the proximal, and then it's going to taper down to probably around a 9 or an 8 below. Probably looks like more like an 8 below. So we're going to go ahead. The other thing you could do, and I really implore you guys to do this on the outside, especially if I was going to use a balloon expandable stent here, I would 100% measure this. And how we measure it is either with a measuring ball or with IVUS. You can use an IVUS measurement. Again, obviously you can do that, but you need to have an IVUS, a peripheral, caliber IVUS that you're able to make sure that you see the entire wall to get a luminal area. However, here the other thing is you can also use the Pinnacle destination sheet to go ahead and measure as well. Dr. Wiley has got a laser cut ball that we also have used in the past to be able to measure, but we do that when we do complex aortic stenting or carotid stenting as well. So here, clearly, I think, I'm going to go with the 12. I definitely don't think that going with the 10 is wrong, but I'll just figure we'll go with the 12 because I'm not going to cause any harm in terms of a little bit larger.
Well, that's the beauty of a self-expanding stent. It won't really matter. It will adapt to the diameter of the vessel. So
we chose a 40 here, and I just would like to see how this looks. Now, the beauty of having the other area, the catheter in the left iliac and up in the aorta, is that now you can test. And I think, for those, again, this is for teaching purposes. We normally would not probably do this, but what we do is we're going to go ahead and test it out up top. Go ahead and inject. So we're going to inject. And so now you see you've got this.
It's a perfect length.
The perfect length. I think so too. I mean, you're above the bifurcation. You could argue go with a 30. We do have a 30, but then again with a 30, you may be, hey, you know what, kind of cutting it close and you could miss this. But here the key is you want to flare it and bring it down. So I'm going to ask Dr. Wiley to deploy the stent. So again, I just want to go through the technique prior to him doing it. So what we're going to do is now we have the luxury of having a catheter in the other iliac. So what we're going to do is he's going to flare it, and Ray's going to give a little bit of dye, and it's going to show exactly where it is. Now, if Dr. Wiley wants me to move my camera to different angles to make sure that he's at the ostium, I'm going to do it. It's imperative here that technique is followed, because if you don't hit the ostium, you've failed. Because clearly here, you don't want to be into the aorta. It is not such a tight lesion where you're going to come into the aorta. You're using a self-expanding lesion to give yourself that leeway, self-expanding stent to give yourself that leeway. So now we're going to go ahead. I'm going to come off fluorophade here, Ray. Okay. The lady has a normal creatinine, so we're just going to go ahead and I'm going to give a little dye. I just want to show demonstration purposes. Okay. Go ahead, Dr. Wiley.
I'm going to start flaring.
It's going to start flaring it. This is an EV3. Okay, jump forward. That's very, very common.
And you can also see from the previous picture, find like a bony landmark that corresponds to the ostium. Looks like to be that straight line of the upper. The lower part of the upper vertebrae is a part where the ostium is. So,
exactly. Okay. Now you see Dr. Wiley's flaring it.
Now he's perfect.
Now stop there. Now a little dye. See, now if I need to move this up, I can move it up. See, I'm going to move it up a little bit.
Yep.
See? I'm going to move it up. So if you flare it further than this, it's not going to work. Little dye again, guys. So again, just to show, okay, we're perfect. Dr. Wiley can go when he pleases.
That's a very good example of PK, because it's always, you can always pull, but you can only push forward this self-expanding stent only if it's minimally open.
You see this right now, Dr. Dangus, George? If you see this here, at this stage, I cannot push this stent any further up.
Exactly.
So it's very important that, as Dr. Dangus said, now if Dr. Wiley needs to pull it down, he certainly can do that, but I can't help Dr. Wiley by moving this up. Yeah. So now we're going to give a little test, and I'm sure we're perfect. Go ahead. And it looks very, very good. Everybody's happy. Now Dr. Wiley's going to deploy very, very slowly. Two things in the technique. Not so much in the iliac, but clearly in the SFA. You do not want to pull this particular stent in terms of elongating it. And you can see here, there's your lesion, which is still there.
Yeah,
and then
excellent.
And then we're going to go ahead and cover it. Now we've got it covered. Now I know it's not a pretty result. Okay, I know it's not pretty. Now we're going to balloon it with a 9mm. You have an 802, guys? We have an 804. Give me a 902 balloon. So we're going to balloon it with a 9mm balloon, okay, to try to expand it nicely. And again, we're not going to go crazy. We're going to look at for three things. One is bradycardia, 2 is pain, and obviously 3 is differential expansion of this particular balloon.
Yeah, and I want to also mention that the anticoagulation purposes that PK outlined in the beginning, that the ACT
or 802.
Just around 300 or 280 or something like that is well fit for a prolonged case such as this one, because taking so many views and this and that. One could anticipate that if in a regular practice this case in an experienced lab goes fast, you can handle this case with a much lower ACT in the low 200s, obviously for even lower risks of bleeding.
Oh, absolutely.
But with all these prolonged infusions and testing and this and that, and give me the devices inside.
Right.
Obviously, a lot higher ST.
And George, I totally agree with you. I think in practice, or in our lab here, in any one of our hands, this particular case would have taken 20 minutes at most. From the moment, we wouldn't have probably gotten dual access. We would not have done any of these things that we did in order for demonstration purposes. But clearly, I think it's important to teach the concepts, as we've done here, to go over step by step what we're thinking and what are the possible pitfalls in this particular case.
Exactly.
So while I wait for the 20mm balloon, do we have a Reef HP 8020? Do we have a Reef HP 8020?
A 20 or 30 balloon would be good, whatever they have.
Yeah, so I want to go with a smaller balloon, and we have an 8020 Reef. Now, the nice thing about the Reef is that it's a high-pressure balloon. They say it's non-compliant, but it's truly not non-compliant. It's really very little semi-compliant. So, I'm going to go with this, again, to prevent that differential expansion that I'm a little concerned about. So I've got this 802 balloon. This is an Invitech balloon, which is now obviously owned by Medtronic. The other balloons that you could use if you're looking for non-compliant balloon is really to use the Dorado. The Dorado balloon, again, is something that works quite well as well. in these type of very non-compliant lesions. We do not have that in our lab right now, but I mean, hopefully in the future we will be getting it. So as always with any lab, we want to watch inventory control, so we're really trying to choose our products. So here we got a rail, and we're going to go forward. And I'm just going to go to coronary guys for me so they can see much better. Okay. So you can see here, I'm going to go right across the lesion. And I'm going to have Dr. Wiley just go ahead, go very slowly.
That's another good technical tip. If you want to plan to work on fluoro, it would be good to select the coronary, 15 frames per second, fluoro. It's sharper than the fluoroscopy associated with the this DSA peripheral package.
Yep. So now we're going up slowly with this balloon. So nominal, I think is 10 guys, right? Right? Okay, 4.
You could go higher a little bit with this.
Right, no, he's going up slow. We always go up slowly, and I think it's extremely, extremely important to really show that we're going slowly. Again, watching two things: watching the patient, watching the heart rate. 8, 9. You go to 10. Okay, go to 10. Go a little bit higher, 11. But since this is a high pressure balloon, you have a little pain, hon? Any pain?
Do you have pain? Are you having pain?
Okay.
I guess not.
So she's not having pain, and it's important. You see that response that we had in our team where we go ahead and see what the patient moved. And I think it's very important to have that subtle judgment on what's happening. Okay? She's having a little bit of discomfort. So down. So now I'm going to watch the pressure. Okay? Now as it comes down, I'm going to watch how my pressure responds. Since I have 2 transducers, if the pressure drops, then there's clearly a problem. There is no drop in pressure.
We can already see that the indentation is much less.
It's much less. And you know, you could go higher, but now so what I'm going to teach here is how to get into the stent. And here you're just going to advance it using the balloon as your dilator. Now, God forbid, I perfed, right? Now I have complete control in the distal aorta. See that right there, what we just showed? That is the particular thing which is very, very important in these type of lesions. When the patient has pain, you have to suspect, like I said, you can work it out, perforation or obviously, you know, impending perforation. So in that situation, you want to have control proximal. Now, God forbid, the patient is perfed. Now, say we have perfed. Now I've got my sheath across the perforated spot. I can now either occlude proximally while we get all our stuff ready, our coverage stent ready. Once we get our coverage stent ready, down with the balloon, walk the balloon out, sheath across the stent like we have it. Then I'm actually advancing my coverage stent through my sheath, not across the stent struts. So when it's going through my sheath, it's very safe. I can place it properly, unsheath the coverage stent, and go up with the coverage stent. I think technique is extremely important. Hold your breath, hon. 1 second. Inject. And you know, honestly, this is an extremely acceptable result, and I think it's a very good result. We've gotten rid of the gradient. Angiographically, we've made it probably a 30% residual at best. She had pain. So if I go with a 9mm balloon, I have to be expecting problems.
Yep.
I've achieved my goal. I've gotten rid of the gradient. The translational gradient at rest is gone. She will feel tremendously better when she goes home and does what she has to do. We have to work on her stopping smoking, and we have to work on her obviously getting into a better cardiovascular health modifier risk factors. As far as antiplatelet therapy here, and I leave that to you, Dr. Dangus and George, in terms of what you would suggest. I mean, in our lab, we give aspirin and Plavix.
I would suggest aspirin and Plavix, and I think the point of PK is very well taken, that we accept a 30% residual with a non-covered self-expanding stent. And if someone is driven for whatever reason, in another similar case, extremely important to achieve a better and a perfect angiographic result, because the gradient might have been bigger or whatever other things, then if patient has mild discomfort, I would say that the choice of that stent from a get-go could have been in those other cases on the cover type, so you can really go up with your 9 or 10mm balloons. But there is no such reason here today, so therefore this self-expanding stent has adapted very well to the distal common iliac, and I think we're in very good shape.
George, I think it's important to mention also that this is a topic that Prakash reiterates over and over to our fellows. is the fact that we had learned from the Dutch trial that the main risk factor for stent fracture is actually calcification. So you really don't want to overdo that post-balloon dilatation. So if you have a reasonable result, you decrease the gradient, that's all you need.
You know, having said that, as we know in this area, the flexion extension in this area is really very minimal. But clearly, I mean, it's important to remember that you do also want to watch what Dr. Wiley is saying. To me, here, it's all about perforation. It's about getting my result, reducing my resting gradients, and getting out in a very safe result for my patient and for myself. Very, very clearly here, she had pain with an 8-millimeter balloon. We went a little bit above nominal because it was a non-compliant balloon. We went up to about 12 atmospheres. When she had the pain, we stopped, and now we have resolution of the gradient, an acceptable angiographic result, safe outcome for the patient, thank God, and a good teaching case for you all. And I think we're just about out of time. So I know this may have looked like a simple case, but as you see, you've got incredible amounts of talking points to learn in each one of these patients.
Yeah, PK, every case is easy if it's successfully completed. And every case is not so easy if problems are encountered. So,
absolutely.
This case went beautifully. It was a very difficult situation of a very eccentric, extremely calcified focal lesion of a very large common iliac artery. PK chose a technique of sequential balloon inflation followed by a longer self-expanding stent deployment and a post-dilation with a bigger balloon than before, but still smaller than the nominal of the cover of the self-expanding stent, which actually yielded a great result with about a 20%, 25% residual and zero gradient, which is the most important.
Now,
and,
George, just to finish, I want to just tell everybody we're going to be building the content of our website with Dr. Sharma has advised us. What we're planning on doing is going ahead and posting interesting articles on the website. We're going to have also, obviously, all the talks that are given on the website are going to be downloadable very soon for you guys to use in your own practices. Number three, what's also going to happen is that we're going to ask for cases to be presented by you guys in terms of if you want to go ahead and submit an interesting case to us. Now, all this is obviously a lot of ambitious things that we want to do, but it's going to start, and it's going to start in the next month or so. So, you know, we're planning on really making this a very interactive website. Yes, you can go look at the cases we've done, the wonderful discussions we have with Dr. Dangus and all of you, but more importantly is at your leisure, you're going to have articles that you can go and read. It'll be a good resource. We're going to post a case of the month that we do here in our lab that's interesting onto the website and really try to build the content of the website. So this way, you know, it'll be a very useful website for you guys. You know, I think as a whole, as we try to evolve this into a very educational piece, I think that'll be a very important part that you have, you know, reference articles and journal articles that you can read in your busy practices that you may not necessarily have time to go and look on your own. So every month, I want you guys to go back to the website, look at it, and you know, look for these new things, which will hopefully happening definitely by June, but hopefully in May.
Great. So let's meet again on May 23rd at 8 a.m. Eastern Standard Time. And let's remind everybody to visit www.cccsymposium.org in order to be able to register and with a significant discount ahead of time of the June 13 to 16 live symposium of complex coronary and vascular cases here at the Mount Sinai Medical Center in Manhattan. And thank you again for attending our live webcast.